Okay, well, I'm Naomi. For those who don't know me, I graduated last year, I guess. So it's been 2 years now. It's been 2 years. Yeah, last year. I did EM here with all of you guys, and then I did a palliative care fellowship. So this is just a topic that's very dear to my heart because I think it's very important for us ER doctors to know. So I'm going to be talking about how to care for patients that are end of life in the ER. I know it's early and it's not a cheery topic, but like I said, I do think it's very important. So I hope you are able to get something out of this and maybe apply it to your practice in the future. That's not it. Okay, so we're going to talk about why this is important, how to actually manage pain and symptoms during end-of-life care, the ethics behind it, and why doctors might feel uncomfortable with it, and how we can adjust and titrate these agents, okay? So why is this important? And I think this is something very important to know. We cannot save everyone. And I don't mean this in a depressing way. That is just nature. And we are not going to be able to perform CPR in a successful way in a lot of our patients. And that's just how it works. And so when death is near and doctors feel uncomfortable that they can't do anything else, we oftentimes fail at treating pain and symptoms. And it comes from the fact that we feel uncomfortable with hastening death. But ultimately, we took an oath, and part of that oath does state that if we cannot heal or cure, we at least can alleviate pain and suffering. And we're really not in the business of letting people suffer. We should treat pain and we should treat symptoms whenever we're allowed. And we have the medications to do so. So I invite you to go ahead and do it. I don't know if anyone has actually read the palliative care section in Cincinnati. Don't. It's actually very useless. It's about 2.5 pages long, but it does have this really good line that I really like. The relief of suffering is the primary goal of medicine, and there are few places with greater suffering that patients that are in the ED. So I think this is really very important to know, and that for you guys to take to heart that you can treat these symptoms and pain, and you should do it. But I do want to highlight the gap that exists between treating pain and symptoms during end-of-life care and the amount of patients that we see in the ER that actually die. So this is a cohort study. It was a retrospective cohort study that was done in the United States. It took about a third of the ED visits throughout the whole nation, and then they extrapolated that using census data of people that visit the emergency department and the amount of people reported that died in the emergency departments in the United States. And they noted this number to kind of go around 11% every year. So 11% of the patients that we see die in the ER. So this is actually a very common pathology, probably more common than, using a slit lamp and other things. And so I just want to highlight that gap of how important it is for us to treat these symptoms. And this is why emergency medicine practitioners should be able to identify patients who end-of-life care is necessary and have the resources to deliver this care. So learning point number 1, patients do not have to be DNR/DNI. They do not have to be comfort care to receive pain medications, as pain medications can be delivered with life-sustaining therapies. You can be on pressors, you can be intubated, and you can be on opioids for pain and symptom control at the same time. They are not mutually exclusive, okay? Regardless of patient prognosis, release of suffering should be the primary goal. It's usually more helpful if the family, next of kin, healthcare agent are also on board with this plan. But based on at least where I work now, we just tell patients and families when they feel uncomfortable with this that we're just not allowing people to suffer, and we would provide this therapy regardless if they feel comfortable or not, unfortunately. So how can we identify dying patients? As much as we don't like to prognosticate because we feel uncomfortable with the uncertainty of it, I can tell that by the end of residency, you'll feel very comfortable telling, I think this patient's gonna die. I think this patient kind of has hours to days at the most. And I think that as much as we don't like to tell that families, at least we know in between ourselves. And so we should use that to try and guide our management. This is, just so you know, applicable for patients that are going through the active dying stage and that we expect for them to survive for sure hours to days. So there's no actual rule, but these are things that you can look out for. People will start to get progressively more lethargic, speaking less, eating less throughout the last week of life. They have increase in pain and discomfort. They have skin mottling, and they just kind of like all the fluid pools to the backside of their body. They have significantly decreased urine output. They have very abnormal breathing patterns with episodes of apnea and tachypnea in between. They're unable to fully close their eyes. This sounds really creepy, and I know you've seen these patients, and it's unclear why, but they can't fully close their eyes. And they also have hyperextended neck. They lose the capacity to hold their neck, which is what causes a lot of secretion buildup in the back of the mouth and throat and makes this really weird death rattle sound. So the early stages of how you can identify someone is nearing end of life. Is they're bedbound, they lose the interest or ability to take anything by mouth. Their cognitive changes that you can see, they start to sleep all the time. They have very minimal amount of alertness during the day. In the middle stage, they just have further declining mental status, lethargic, barely being awake. And then on the late stages, which is the usual that we see in the ED, is they're mostly fully comatose. They have the altered respiratory pattern, the mottled extremities, the cold extremities, like I explained. So if these patients can't talk to you, how do we know if they're in pain or not? How can we treat these symptoms? So first of all, you can ask the family. They know the patient better. They can probably clue you in, but there are actually some scales that you could take a look at. So this is the pain and advanced dementia scale. It was validated for patients with dementia, but it was subsequently validated for patients that just can't speak to you or tell you what they're feeling. So it was also validated to be used in palliative care for end-of-life patients that can't really tell you about their symptoms. This is a 10-point scale, and it takes into account the way you're breathing, if you're having labor breathing, if you're having moaning and groaning, if you have any facial expression that indicates that you might be uncomfortable, your body language, if you're tense, if you're fidgety, and if you're able to console someone that's kind of crying and moaning. This is on MD Calc, so you don't have to learn it. Just know that it exists, so you can actually look at this 10-point scale and decide if you need to treat your patient's pain and symptoms. Anything more than 3 and 4 are considered a moderate level of pain, and this interferes with normal sleep patterns and comfort. So anything more than 4, you should really be treating as much as you can. This is the nonverbal pain scale, which was also validated. I like this one a little bit better because it takes into account physiologic vital signs like heart rate, increase in blood pressure, increase in respiratory rate. And when someone has been comfortable throughout and then they have a spike in their heart rate or systolic blood pressure or just being more tachypnic out of nowhere, that is also a sign of uncontrolled pain and dyspnea that should be considered treating. But it's also a 10-point scale, and anything more than 4 out of 10, you should consider treating with symptoms. So the learning point number 2 is during end of life, people are going to be significantly sedated as they enter the comatose stage. This shouldn't be a reason for you not to give opioids. Mental status alone does not indicate that someone is comfortable or not. You should base it on the pain scales that I just told you about, okay? Not because they're sedated. In fact, during the end of life, you expect them to have no mental status whatsoever, and you're titrating the opioids to comfort based on the other symptoms explained on the scale, okay? Whenever you have these patients, you should treat any underlying pathology and then consider using opioids if that's not working. For example, you have someone with end-stage COPD, you should do the usual things, NEBs, steroids, BiPAP if they can tolerate it. If they have massive pleural effusion, you can consider talking to the family and patient if having an intervention like this would be within goals to treat their symptoms, okay? But if there's nothing else really medically that you can offer, then that's when we would start thinking about opioids, okay? One very important thing, and they're just highlighting that there are many studies out there that show that opioids do not hasten death, especially in the hospice population. So there are many studies. This one was with COPD patients, and they noted that it doesn't increase CO2 retention levels in blood. These three is in advanced cancer patients on both hospice and hospital setting. And I titrated and noted that there is no difference in outcome or increase shortened survival when patients are treated with symptoms. In fact, there are actually some studies that show that once the patient is comfortable, they might even survive for a little bit longer. So take that as you want. Also, the World Health Organization recommends opioids as the first line of treatment for any severe pathology, especially end-stage cancer and dyspnea. And it is considered safe treatment. If you're still having issues about hastening death, there is this doctrine under the ethics paradigm, and it's called the doctrine of double effect. I don't really think it's applied, but you know, when you're offering a therapy and the therapy, what you want to do, the desirable outcome is to help the patient, and you're doing it to relief of suffering, then it is ethically permissible, even if it might hasten death. But we just proved that it doesn't really hasten death. So some people use this as an explanation. I don't even think it applies because I don't think opioids hasten death, but just if you're still having issues, it is ethically permissible by all organizations because the intended effect of giving this medication is for symptom control and not for hastening death. And it is legal. So let's just get into the nitty-gritty of it. How do we choose an opioid and what considerations do we have to have? So unfortunately, we have to talk a little bit about pharmacology. I know you all love this class in medical school, but most important thing you need to know is that IV opioids reach a steady state in the blood within 6 to 10 minutes, okay? And the reason why this is important is that in 6 to 10 minutes, your patient is still uncomfortable. That is not the dose for them. That's not going to be the dose for them. They need probably more because in 6 minutes, it should have reached enacted in a reasonable amount. And you should be reassessing your patients every 10 minutes just to make sure that you have find the right dose for them. You can also consider sub-Q IM dosing, which we would have to reevaluate your patients every 30 minutes. But so this is just, I would really recommend that when you don't have IV access, really difficult vascular path. For end of life, I don't really recommend PO/PR dosing because it's unsafe for these patients to be swallowing anyway. And then pharmacokinetics in terms of which opioids act faster. Just so you know, the ones that we do have available, fentanyl right here is the fastest acting opioid. So this one should reach a steady state within 5 to 6 minutes. And you can reassess your patients every 6 minutes, and you can redose this medication every 6 to 10 minutes until you achieve a target effect. And then the other ones we use, I think it would be methadone is the second one to reach higher levels, and then Dilaudid, and then morphine is the slowest one of all of them, just so you know about when you can be reassessing your patients. Overall, as a rule, you can just use 15 minutes. All will be within that window for you to see if a patient has reached a steady state in terms of the opioid levels that are going to be effective for them. So if you're starting these medications in the ER, then you should start low and go slow. And this is for opioid naive patients, someone that has never taken opioids. In this case, I wouldn't really consider weight-based dosing, you know, how you use like 1 milligram per kilo for morphine. I would actually just use the lowest dose possible, like 1 to 2 milligrams of morphine, 0.2 of dilaudid, 12 of fentanyl, and I would start from there. Just because when people are dying, they have usually multi-organ failure, and that just can affect the way your body metabolizes the medication. So you should go to the lowest dose available and go up from there. And how can we do that? So there is some math involved, and I'm sorry, but please pay attention because this is the important part. So you check your levels on the pain scale, like I told you before, the pain at scale or NVPS. You administer the opioid, you reassess them in 10 to 15 minutes. You see that their pain is relieved about 75%, and that will be the dose that you will keep giving the patient every 1 to 2 hours for comfort. Like, for example, you gave them 0.2 of dilaudid, the pain level went from a 9 to a 2, then this means this is a reasonable dose for the patient, and you can redose that every 1 to 2 hours. You would write it 0.2 hydromorphone dilaudid, PRN for pain and dyspnea based on nonverbal pain scale, so that the nurse knows to give it, okay? If you, let's say, give them the 0.2 of dilaudid and there was no relief whatsoever, the patient still looks super uncomfortable, looks like shit, super tachypnic, then you would double that dose. You do 100% increase the next time you give them 0.4, and you reassess them again in 15 minutes and see how they're doing. If they're doing better at that point, then you take the sum of the first and second dose, and that would be the dose that you would give every other hour. So that means that you gave them 0.2, it didn't work, then you gave them 0.4 and it worked. The next dose for that person would be 0.6 every 1 to 2 hours, okay? Does that make sense? Yeah, go ahead. So this is more for end of life care. If you're having a patient with pain and uncontrolled symptoms, I would recommend that you use a PCA instead of doing this, because it's a little bit safer and the patient has more autonomy and control of their pain. Maybe we can talk about that later offline, but it is still the same background, or like the same idea. Yes. And then if you know that, let's say you gave the 0.2 and it was moderate relief, the next dose, you, instead of giving 0.4, you give them 0.3, and you know that they're doing better. So the dose for this person instead of 0.6 would be 0.5 every 1 to 2 hours. Does that make sense? So let's just do a case so you guys can make a little bit more sense out of it. So we have an 84-year-old male patient with end-stage COPD. He's at 4 liters baseline oxygen. He comes to the ER. He has a pneumonia. You do the usual things. You give NABs, steroids, antibiotics. The patient's still uncomfortable and very dyspneic. You consider high-flow nasal cannula. You put them on BiPAP, but the patient takes it away no matter how much you put it back on. The wife tells you he hasn't doing very well for the past couple of months. He's not really eating, he's sleeping all day. You discuss with the wife that you think that this patient is entering the active dying stage, and the wife tells you that she thought that that was coming and she just wants you to make sure that the patient is comfortable. She agrees to start medications for pain and for dyspnea. You determine this patient to have a pain scale of 8 out of 10, and you decide them to give them dilaudid. You give them 0.2 milligrams of IV dilaudid, and then you reassess them, and his pain didn't really decrease at all. So then what would his next dose be? Okay, so you dose the 0.4, you increase it 100% because the patient had very minimal relief. And in 15 minutes, you know that the patient's actually very comfortable. The wife tells you that he looks more relaxed and he's breathing more deeply and better. So the next dose that you would give in 1 to 2 hours would be 0.6 PRN for both pain and or dyspnea, okay? So this is for opioid naive patients. just be aware, the learning point here is that in 15 minutes, when the opioid should have achieved steady state in the blood and the patient should have received some comfort, if in 15 minutes they have not, then that's not the dose for them. You just keep increasing until you find that dose. Just don't be afraid, okay? You have the antidote anyway, so. Learning point number 4 is there is no ceiling dose for opioids. You continue to titrate to comfort, not to the level or amount of opioids that you're given, okay? This is not true for the combined, like the buprenorphine dosing, but we don't really use that in end of life, nor do we have it in the ER IV formulation, so I don't think it matters. But this is true for methadone, fentanyl, hydromorphone, morphine, okay? So when you have a patient that's already on chronic opioid therapy, the math is a little different, but it's actually, I feel, a little bit easier. So you have to calculate the total amount of opioids that they're taking in 24 hours, and then you convert that to an IV dosing, and then you continue to use PRN medications. So in terms of how do you calculate what should be used as PRN boluses for this person, it should be 10% of what they're getting in 24 hours. And this part here is very important. So not all PO opioids are available IV. So if you're switching a patient from, let's say, oxycodone to a different opioid IV, because oxy is not available IV, you have to account for cross tolerance. It just means this patient has been on oxy for a while, they are tolerant to it. That doesn't mean they'll react the same way to a different opioid. So you should decrease it about 25% just to make sure that you're not giving in a higher dose that could overdose them. Does that make sense? No? Okay. These are the conversion tables that you can use to go from one opioid to the other. This is for IV and PO. This is available online anywhere, so you also don't have to learn this. Just know that it exists and that you have to do some math to get from one to the other. So let's do a case for this one so you guys can visualize it better. So we have a 76-year-old male. He has lung cancer, metastatic. He's already on home hospice. The family tells you that they're bringing him in today because they're having a lot of issues controlling his symptoms at home. He takes OxyContin 60 milligrams every 8 hours, and he takes oxycodone immediate release, which is a short-acting medication, 20 milligrams every 4 hours for uncontrolled pain. Patient is still moaning and groaning. He's having labored respirations. He's not able to talk to you. He has not been able to take any medications last night since he acutely decompensated. And before that, he was taking the PRN doses every 4 hours around the clock. You talked about doing a continuous opioid infusion for symptom control. So how do we do that? So we're saying this patient is taking OxyContin 60 milligrams every 8 hours. So 60 times 3 is 180. So he's taking a total of 100 milligrams of long-acting opioid, and we want to convert that to an IV formulation that we could give him. The wife also told you that he's taking the immediate release every 4 hours around the clock. So that means 20 times 6 is 120. And this is the total amount of opiates he's taking in a day to have some symptom control, okay? So how do we convert that from oxy to morphine? We know that that is 300 milligrams of oxy. And then if we go back, we see here that 20 milligrams of morphine is equal to 10 milligrams IV, 20 milligrams of oxy is equal to 10 milligrams IV of morphine. So that's our convection factor, 2:1. As we see it right here. And that is a total of 150 milligrams of IV morphine. I know that sounds like a lot, but that is in 24 hours. So you divide that by 24 hours, and then what you get is what you'll be giving every hour, which actually doesn't come out to be that much. You account for cross tolerance because he was taking oxy and he's never taken morphine before. And so you have to decrease it by 25%, which is what I'm multiplying here by 0.75. So I'm taking 75% of the total, and that is what he would be getting in 24 hours. And then when you divide this by 24, it's actually just getting 4 milligrams of morphine every hour, which is not a lot. It just sounds like a scary number, but it's actually super reasonable and a low dose. Does that make sense? Or have I lost you? Okay. And then for the PRN medications, and just to answer your question, this is more applicable to how PCAs would work. 10% of the total daily dose of the 115 that he's getting would be what you should be giving every 30 minutes to an hour for uncontrolled symptoms. So if he's getting a morphine 4.5 per hour, what he should be getting as a PRN dose is 11 milligrams every 30 minutes to an hour for uncontrolled symptoms. And this should be given PRN by the nurse. Some considerations to think about during end of life when you're having multi-organ dysfunction, both liver and kidneys. You have to take that into account. You shouldn't really be given morphine for patients that are end-stage renal. You can give hydromorphone throughout, but you might have to increase the frequency dosing. Instead of doing it Q1 hour, maybe doing it Q2. Fentanyl is usually pretty safe across the board, and methadone is actually what I consider to be the easiest and safest one, but I know that people have difficulties dosing this one IV. But I think fentanyl is the most easier to give across the board, so I would invite you to consider that one. That being said, I don't think, and correct me if I'm wrong, I know when they go to the floors, they don't do the IV anymore. Like the nurses don't push that, so that might be another consideration that you guys should think about. Some adverse effects for opioids, there's constipation, it can cause nausea, myoclonus. This is really the biggest issues as to why you have to take into consideration renal failure. It's not really because of the risk of respiratory depression. Yes, that is true for every opioid, but you can get this paradoxical effect of opioid-induced hyperalgesia and these myoclonus that might look like seizures. That is actual opioid toxicity, and at that point you have to consider decreasing your dose, and that's why you just have to consider it. But otherwise, opioids are pretty safe. And then what I told you for pain also actually works for dyspnea. Dyspnea is a subjective experience of having breathing discomfort, and it's distressing to both patients and to families, and is associated to a lot of anxiety. Patient can't breathe, they feel like you're drowning, they get anxiety, they start hyperventilating, and it makes it worse, and it just feeds on itself. So it's unclear why exactly opioids work for refractory dyspnea, but it is very well known to work, especially at low doses. So you can consider for these cases, even PO doses if patient is able to swallow, but if not, the same that I just explained for pain would be the same way that it would work for dyspnea, and the same way to titrate it really. Adjuvants that you can give for comfort the patients that are having significant dyspnea is just supplemental oxygen. A handheld fan helps a lot. You can do benzodiazepines, and chlorpromazine is the only antipsychotic that actually works also for end-of-life dyspnea and the anxiety related to lack of breathlessness. And other things to know about, there is not a lot of evidence that these medications work for secretions. There's only anecdotal evidence. The American Academy of Hospice and Palliative Medicine still recommends to give it, but these medications are to decrease secretions and the death rattle I talked to you about the pooling of saliva in the back of the mouth. I would say that glycopyrrolate is the best one because it doesn't cross the blood-brain barrier, so you're not having that anticholinergic effect of alter mental status, especially in older people. But sometimes that just doesn't do the trick, and you can do atropine eye drops in the mouth, and that also helps, works really well. And then our take-home points is that it's our job to treat pain and suffering. that you can deliver and offer these with aggressive medical care or with comfort care. They're not mutually exclusive. They do not hasten death. They help with dyspnea, anxiety, and pain. They help with comfort during end of life. If you're starting opioids in the ER and the patient are opioid naive, start low and keep going titrating every subsequent dose every 15 minutes until you feel the patient is comfortable. And then the total dose is what you would keep giving. And for patients on chronic opioid therapy, consider switching that to an IV continuous infusion and always account for cross tolerance where you're going from opioid A to opioid B. And that's it.
So if you have, like in the case that you presented, the patient coming in that's home hospice on chronic opioid therapy, switching them to IV continuous infusion. In terms of ED disposition, can you send this person back home? Do they need to be admitted?
So you can send them home. It's difficult to arrange that from the ED for the hospice to get them a PCA at home. But it sounds like more likely you would be admitting them for end of life care because they can't control the symptoms at home. So no, I wouldn't put them on OBS.
So I know you're saying like fentanyl is like more better tolerated, but like obviously with IV it's a little bit harder. Is there any room for doing like fentanyl patches or are those too low?
No, you can. The problem is a fentanyl patch will reach steady state about 12 to 24 hours after placing it. So you're not helping the patient in the acute stage. So you'll help them tomorrow, and that's just not very helpful. I know I did have when I did do per diem, I had a patient in CCT and I tried to admit them on fentanyl and the team was like, absolutely not. So we had to keep them until the fentanyl patch kicked in. And then they were like, okay, fine. So the patient was in the ER for like 12 hours. But that is just a hospital, like institutional policy problem. And that shouldn't really guide what you're doing for the patient.
That was like more my dispo question. Like they don't do like morphine drip on the floor or any drips on the floor, correct? So
maybe that should be your QI project.
like the ICU not been like take an ICU bed for this for drips and then the floor is not take that correct?
Correct.
Correct. It's wrong, but it is correct.
That's how it works.
Where I work?
Yeah.
So where I work, we have a palliative care unit, so we admit these patients for our unit for end of life care. But if patients are already in the ICU and they need aggressive symptom control in a monitor setting, that is actually criteria for ICU admission, but you should take that up with your ICU docs.